me. I'm Shravani Dev, the research assistant to the SarvArogya Rise Foundation. Welcome all on the sixth webinar of SarvArogya on the topic Advancing Gender Equality Through a Life Course Lens, Learning and Opportunities. We are honored to have Dr. Nandita Bhan, ma'am, as an expert today. Please keep your mics muted for discipline and save your question to be asked to the expert later. Now, I request Neha ma'am, Editorial Director, SarvArogya The Rise Foundation, to welcome our expert and provide the program overview for today.
Thank you, Shravani. So, good evening, everyone. I'm delighted to welcome you all to the sixth webinar of SarvArogya. Also, I would like to extend my sincere gratitude to Prasad Institute of Medical Sciences, Lucknow, for supporting this initiative. First of all, on behalf of entire The Rise family, I welcome Dr. Nandita Bhan, ma'am, who is the professor and the vice dean, academic affairs, Jindal School of Public Health and Human Development. We are truly honored to have you, ma'am, with us today to share your insights on advancing gender equality through a life course lens, learning and opportunities. But before Dr. Nandita ma'am expresses her thought, let's set the context right. Why this SarvArogya webinar? See, now gender inequality, a phrase we hear every day. We debate it, write about it, make policies around it. A phrase that has been a lived reality for millions of women like us. How? Because it is this inequality that decides who gets enough food, who goes to school, who can speak about health, who can seek medical care, and at times who survives. That is why gender inequality is not just a social issue, it becomes a public health issue. Now, see, health is a domain where social norms, family structures, economic realities, and public policies they all intersect. Also, these inequalities do not appear suddenly. See, when a woman becomes pregnant, they begin much earlier and they accumulate throughout the life. In fact, till today, in many houses where the resources are constrained, there is disparity in the nutrition received by the boys and the girls. Question around menstruation, reproductive health, mental health are often hushed up. Even if we consider that these women become aware of their health needs. Another challenge that emerges is the agency, from the question of going to the doctor to planning a pregnancy or even deciding where to deliver a child, the decision is shaped by their husbands, parents, mother in law, aunt, uncle, neighbor, and even God. Yet her own choice, her own voice remains unheard. And let's suppose she attains this autonomy. She embraces the idea of my body, my choice. But does she have the economic independence to take care of her own health? A woman may know that she requires treatment, but can she afford the diagnostic tests? Can she purchase the medicines on her own? Can she revisit the hospitals for follow ups without sacrificing her household responsibilities? Take anemia, for example. India continues to have one of the highest anemia burdens among women and adolescent girls, despite having spent thousands of crores on distribution of the iron folic acid. The reason? Lack of treatment adherence. These women take medicine for few days, but as soon as they start feeling a little better, they stop. The treatment stop. And when this treatment stops, the health outcomes begins to deteriorate. Now the health outcomes does not depend on these women alone. It also depends upon the ecosystem around, including the health ecosystem. Now, this also includes the interaction between the women and the health system. See, we need to understand this. Accessibility is not just the presence of hospital within a certain distance. It is also about that whether the healthcare environment is respectful. Is it confidential? Is it free from any judgment? Let us understand this through an example. Imagine a 16 or a 17-year-old unmarried girl. She becomes pregnant. She cannot turn to her parents, the society will judge. She hesitates to go to the hospital. Why? She fears the legal consequences under the POXO. So, where does she go? To a quack, to an untrained provider. And before anyone realizes, this preventable crisis turns into a tragedy. And this is just one example. Women across the life course face different barriers. Say, adolescents require mental health support, reproductive health education. Older women require attention in osteoporosis, cancer, non communicable diseases. When we talk about the uh, vision of Swasth Bharat, say Viksit Bharat, we need to understand that the least we can do is to at least hear these women out. We as policy institutions, research foundation, university ecosystem need to focus beyond just providing episodic care. We need to build systems which support these women throughout their lives. And these questions are not just social in nature, they are proper, ethical, legal, and public health questions. And this is precisely the main discussion we aim to start through this webinar. Shravani, over to you. Shravani?
Hello. Yeah.
Yes.
Now I request Ma'am Sneha Ma'am to share a brief profile of our esteemed guest. Before we move on to the next presentation, I think Ma'am will be
Thank,
presenting.
thank you,
Thank
Shravani. Professor Nandita Bhan is a professor and vice dean academic affairs at the Jindal School of Public Health at the OP Jindal Global University. Her teaching and research focuses on gender equality, global development, and social determinants of health. Through her research, she aims to understand the determinants of health and the well being of women and girls through life course, including issues such as child marriage, health seeking behavior, sexual and reproductive health programs, gender based violence, and women's engagement with health systems. Her research has also engaged with climate resilience, adolescence agency, measurement, and data gaps in monitoring and evaluation survey. It's truly an honor to host you, ma'am, today. Thank you. Over to you, ma'am.
Thank you so much, Sneha and other colleagues. I hope you can hear me well. I've not previously presented through, a meet, so please, I apologize already for any lapses related to sharing. But please give me a minute, and I will share some slides. Um, Second. No, it's sorry, my screen is not moving. Share, yes, share entire screen. So I hope that you are able to see my presentation. I'm
Yes.
not able to see you anymore. Okay, great. Wonderful. So thank you so much. And I think, honestly, the introduction by you, Sneha, was so comprehensive that I'm a little nervous presenting what I'm presenting. But this is actually wonderful opportunity to meet all of you and have this discussion. So today I'm just going to talk a little bit about the overview to the questions related to gender equality, particularly in health. I'm going to start like academics do with, a few key concepts and constructs that we all use very loosely. Sometimes we don't use them accurately. And other times we use them interchangeably. So I'm just going to talk a little bit briefly with getting us all to the foundations of what do we mean when we say what we say. The second part of my presentation will be, although you all probably don't need an explanation, but I think those of us who are working on gender equality in a way have to constantly prove ourselves as to why does this matter. It may seem obvious to, this group and, some of the other sort of more nuanced students out there. But even today, women are constantly fighting for their rights in various spaces, like beautifully articulated by you. And these questions around why this matters still, affect us today. And the third part that I'll talk about is just briefly a few issues, some of which, you've alluded to very nicely in your introduction, but some a broad overview of where society is. And I think it's very important in this conversation, to be as nuanced as possible. I think sometimes the gender discourse tends to be very, in a way, binary, like, good, bad, yes, no. But actually, it is for us as people who are working in the broader field of development, health, education, to have more nuanced perspectives of what is really going on today. Okay, so obviously, that even though many people use sex and gender sometimes interchangeably, but they are very different concepts. When we say sex, we mean biological differences. And, to the largest extent, we've often taught and believed that these are biological differences that are largely assigned at birth and are unchangeable. But today we know that in many countries, medical interventions are possible. But when we say gender, we are talking about a broader gamut of socially constructed roles, status, relationships, behaviors. And these, of course, where the gender spectrum lies can differ by country and by society, culture, community. And so we can, frankly, realistically, around the world, never be on the same page. Women cannot have the same rights everywhere in the same exact way. That contextuality of where we are needs to be respected. And largely some of these gender inequities have been these have been strongly discussed in the global indicators like sustainable development goals, and I think you're all obviously all familiar with goal 5. And countries have been, in a way, pushed, as you know, to respect the commitments that they have made with respect to signing some of these global charters. But underlying the gender inequities that we often talk about is the question of power, and asking the question, where does power lie? But what does power even mean? How do we even define power? So, from a more perhaps academic perspective, we say power is the ability to influence the behaviors of others. And the two major components of power are authority, and that authority can operate in various ways. Authority meaning authority over your discipline, authority over your field. Power is not just physical power, right? Like power is also influence. So today, a lot of young people are, or are in this sort of realm where there are these influencers. They also have power. So what is power? It's that kind of an intangible element that exists. And when we talk about gender, that power element exists in the ways in which we interact with one another. We have to understand that, when we say power, we also accept that there is some kind of a social contract that, power is exercised and power is accepted. So you don't have to force someone physically to get them to do something. Power can be exercised through laws. Power can be exercised through social structures, through socialization. Socialization meaning how you observe growing up, how things are, and you imbibe them slowly. It's sort of like it permeates you in the ways in which you see gender relations play out in your families. We all often see, women doing a lot of the unpaid labor within the households, and we accept that. And that's sort of socialization. It's not always a good thing, but that's socialization. Power can also be exercised through social nudges. So, you often see that society can often remind women of of their sort of place in society. So you often see that young girls are often told at various points in their lives that they've now grown up and they have to take over the responsibility, or they have to learn how to cook because something will happen to them in the future, or where they will have to. So these are these nudges. So nudge meaning how someone sort of socially reminds you that this is your duty, your authority. So in the gender field, this plays out very well. Now, many people use equality and equity in a way interchangeably. In some ways, I would say equality in a very abstract, total sense may not be possible. I know it's a little bit, perhaps, not a good thing to say that, but it's true. We are not competing with each other, but what we are competing for is equality in terms of the opportunities that men and women have, and those need to be more equal. So that's why we often, instead of equality, we sometimes prefer to use the word equity. But there is always this kind of tussle going on that no, we need to say equality, but actually we mean equity. And what even when we say equality, what we're trying to say is that we're not saying that men and women are same, because people will often make this argument that okay, men can lift 5 bricks and women can only lift 4, so why should they be paid the same? But we're not talking about that. We're talking about their rights and their opportunities being the same, and without prejudice and stereotypes. And that is why you often hear this word patriarchy. And sometimes I think I see this used a lot more than is actually exercised in some ways in real life. But patriarchy means a kind of a system of beliefs or relationships or values, which is embedded in the ways our political, social, and economic systems work. And in this system, men are considered superior to women. And so this system constantly, in a way, reinforces the power of men over women, as well as inequitable gender relations. So I often actually, when I teach my students, I always tell them that let's not be in this competition of men are patriarchal and women are not, because in society today we have always, we've often seen women also hold patriarchal values. So for example, perhaps the most popular, in a way, example of this is the mother-in-law, who is a woman, but she enforces the patriarchal writ within a household. So women can also enforce patriarchy, and I'm sure that you can think of various different ways. But patriarchy is often enforced through culture, and culture becomes the biggest symbol, and sort of the biggest, I would say, it's the biggest challenge for us, especially when we are working in health, to think about what are the cultural norms and customs that go on enforcing that patriarchy. So we can see it sometimes when we are talking about menstruation, we can see when we're talking about abortion, but essentially social institutions play a very important role in kind of, they can also play a progressive role. I'm not saying that they are always, in a way, enforcers. They can also break stereotypes, but largely we see religion, and we mean all religions and family structures. Often these are very much enmeshed in as enforcers of that patriarchy, that women must do this, or this is where patriarchy or patriarchal systems are often learned. So an easy example of that is when you're eating lunch, the man will always eat before a woman, or a woman is bringing a hot chapati for a man. You never see that role reversal happen in other ways. Which brings me to this kind of like major, I would say, umbrella term that we, learn in our society today, which is gender norms. And by gender norms, we mean sort of the expectations and standards to which men and women both have to generally conform. So gender norms are not just something related to women, but these are enforcers of how masculinity and femininity needs to play out in society. So again, there are socialization plays an important role in how we think of gender norms. And we constantly, when we are being ourselves, we're constantly thinking about key people in our lives and what is expected of us in terms of our gender identity. Now, what is a life course lens? So, for the longest time, when we've talked about health, we've talked about gender equality, we've often stayed in a very presentist framework where we have thought about. So, if we wanted to solve a problem of a particular phase, we never kind of considered a life course perspective. We never thought of what. So, for example, the example of anemia or undernutrition that Sneha had talked about. So we often thought about undernutrition as being kind of caused by factors that women were facing today, and not thinking about a lifetime of deprivations that have led women to this. So life course lens or life course perspective, which actually, originates in psychology and many other disciplines, even biology and so on, really means understanding the risks and effects of exposures from early life and thinking about critical phases of life, be it gestation, childhood, adolescence, young adulthood, and so on. So we have these periods in our lives as human beings which are critical. Some of these periods actually, even, some of the exposures that we have faced have happened to us even before we were born. So, for example, the in utero period, when our mothers are pregnant with us, right? There's nothing we can do about it, but some of the intergenerational risks play out in such a way that our exposure is determined by the circumstances faced by our mothers in those 9 months. Similarly, today we believe that adolescence and childhood are critical periods where if you are exposed to some forms of adversity, and I don't just mean like economic distress, but even psychological trauma, you are exposed to any experience of domestic violence in the household, these can have life course impacts. So these can affect you much later in life. These sort of manifest as physical or mental health challenges much later in life. So when we say life course lens or life course epidemiology, as we use in my field, we are trying to connect biological, behavioral, social, and lifestyle risks over different periods of life and even interchangeably. My last slide for this section actually is these terms that perhaps you all have encountered in your work, and I just want to make a very quick distinction. I don't want to go too deep into it, but we often use these terms gender neutral, gender aware, gender responsive, and gender transformative, and sometimes we use some of these terms interchangeably. So when we say gender neutral, we mean policies, approaches that disregard gender issues. So, for example, if you are in a workspace, many workspace promotion policies don't regard the domestic labor that women do or the childcare work that women do when they are promoting. This is very true of many places in academia where, promotion policies just don't recognize that women are also doing this double burden. Gender aware are policies or approaches that are cognizant of gender inequities. So, for example, many science organizations today are recognizing that there need to be re-entry policies for women scientists, trained women scientists, to come back to the workspace after they have had their children and so on. So these policies, I would say, are gender aware in a way. Then we have this term gender responsive, which really means an approach or policy that recognizes, but it's also very responsive to it. So it is going that extra mile by recognizing that women need to be supported. So at the workplace or any other domain of life. So the easiest example I can think is that policies or interventions have often said that there must be creches for working women. So an office needs to have a creche area that can support so mothers can work without any sort of stress and so on. And the final one, which we often use thrown around, but we actually don't see it as much, is gender transformative. This means that not only have you recognized that there are gender inequities, but you are trying to reverse them. You are actively trying to undo these power imbalances. So, for example, you often see programs like men bringing their children to work. So, that is sort of saying that, it's not just women who have to deal with the childcare burden, but it's also men who are sort of carers or caregivers of children. Similarly, when men and women both get childcare leave, and in most countries, it's only women who get childcare leave and men get a few days, depending on which sector you're in. But in many countries, and we see this a lot in Nordic countries, is that men and women both get childcare leave. So the idea is that it's not just a woman's role to care for a child, but it's also a man's role. So it is transformative. So I often see many people use gender responsive and gender transformative interchangeably. And that's not true. So you have to be, like I said, because you are sort of into this work, you have to always understand the complexity of what is being said or the nuance of what is being said. Okay, so the second part of my presentation is about why does gender equality matter today? Why should we continue to strive for equality of women? Well, the first argument for that, and I'm going to give you a few, is the human rights perspective, which is that whether it is globally or nationally, there is gender inequality is a moral issue, right? We cannot have half the population not have access to the full scope of their rights and freedoms. So it's a justice issue, right? So the human rights perspective is sort of very absolute and says that no, women and men are equal, and so all the rights must be equal. Now, this often flows into our constitutions nationally. And so there are national constitutional guarantees of what are the rights. And in India, we have a beautiful constitution that talks about women's rights as citizens and looking at civic, economic, political, social rights. So, for example, we have had the right to vote right from the start, which many countries have not had. Women often can stand for political office, and so on. So again, this again varies country by country, but largely these constitutions have been driven by the charters related to human rights. A third perspective, which is an instrumental perspective, which often I see economists give a lot more, is that including women or ensuring the rights of women for their economic and social growth can be an agent of the larger growth of a country. That you can't have a nation grow, you can't have GDP grow if you neglect the contribution of women. So there is this kind of an economic argument. And most of the time, I see this argument being used for women's work, where many countries where GDPs are not staying up, they are arguing that it's women's contribution and women need to be encouraged into the workforce, and that will impact the national growth indicators. So this we call the instrumental perspective. So women being sort of a key to the development or the growth, the desire for economic growth. A fourth argument, which we have seen a lot in health, is that investing in women can lead to wider social benefits. We often say that mother's education is very important because if the mother is educated, then the child is educated, blah, 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 right? So we often try to make the argument that women are a good investment. And if you invest in their growth and development, you will ensure that the children are, cared for. The children also grow. The gender norms are more equitable. Women have more voice in the household. And frankly, we have largely assume this more than we have the evidence. I mean, we have some evidence for this, but this really needs to be revisited because of the question of gender norms. Because we often find that despite women being educated, sometimes they are not able to exercise their autonomy or their voice in the household, right? So we really need to interrogate this question a bit more. Then I think of course the gender equality argument also matters, because we want to talk about women as women needing certain services, and I particularly think of health services during some life course periods more than men. So this argument talks about the vulnerability of women, and that, women, particularly if you think of pregnancy or you think about menstrual hygiene, that biologically women need our investment and our support into and our health services much more than men during some life course periods. So again, an argument is made that these are sort of services that really need to be provided. Another argument relates to the invisibility of women's unpaid work, and the idea that today, and this is not just true for India, this is true globally, that women are really carrying domestic work in all households around the world. Women are at the front line of what we call the care economy, and care economy not just in terms of professional services of care, but the unpaid invisible household care that women provide for children, for older persons, for sick persons, and so on. So a majority of the heavy lifting within the home is being done by women, and it does not get acknowledged until someone comes and monetizes it, right? So when we think of some of these services being externalized to the household, we think of paying for caregivers, then we suddenly realize how much work it is, right? So this idea of women's unpaid work being this, it's like an iceberg where you can only see a small part of it and a large part of it is invisible. It's very much like that. And then finally, in our health sector, we have often, presentation after presentation, we'll often talk about the fact that women are the foundation of the health system. Our health systems around the world are led by community health workers, and, most of them are women actually. And so we have to ensure their rights. But the truth is that when we start to do the research, we find that we don't give them decent salaries, we don't have dignified conditions of work, and so on. So we really need an investment in understanding where are women, or we know where they are, but how are we supporting women in the health services? The reality of women's life. So those were some of the aspects that we had to focus on, but the reality of women's lives is actually quite different. So we see today, and this is very sad, but we often see women at the center of all global humanitarian crises. Be it violence, be it lack of services, women are most acutely affected by humanitarian crises and conflicts, and we see so many around the world today. Similarly, we see that women do not have, well, our constitutions around the world have said a lot of things, but the implementation of those rights are not always, well implemented. So, for example, the right to vote came very late in many countries. Women's participation in public life can be very different depending on where we are. We know that women's work is abysmally low in many countries. Even in India, I think it's rising very, very incrementally and not really seeing the spurt that we want women to see. We find that there is a gender wage gap. This is the sort of secret that no one will tell you. But in many sectors, including the medical system, you will have male and female doctors being paid differently. When men's work gets valued more, the top male consultant will make a better salary than a female consultant. Again, like, these are secrets that we don't want to talk about. And as a result, because women don't receive the support that they need, they often opt out of full-time work, and are more likely to work in perhaps slightly less lower paid part-time occupations that often have no social security safety nets, meaning that they don't have and insurance and other services, because they are not full-time employees. Often women are opting out, and this evidence is not just true in India, it's true in many countries. I've seen recently evidence from Philippines that says that women feel that it's not worth it to be in a full-time employment because they are not getting the returns that they need. They're balancing work at home, and so they decide, okay, I'll step back and I'm going to engage in flexible employment that allows me to do a little bit of work but also manage my home responsibilities, which is a purely rational choice. But what that means is that they get less salary but also often don't have access to insurance and other social safety services. And, we often in health, we often see women as vehicles for other services or services for other people in the household, be it children, be it older persons. But often our conceptualization is not about seeing women as key agents who are fighting for themselves. Similarly, we find, and I think the evidence is there, that vulnerable stages of life, we often pay lip service to it. But when we see policy implementation of programs, these are very weak. Menstrual hygiene is a great example where we have done a bit, but not enough, right? Similarly, I think delivery care, institutional deliveries have really stepped up. I think the government has been in India very, very proactive, and there's been demand side financing, but post delivery care remains weak. So I think there are still areas where we need to be working on. As we said, women's unpaid work is often not acknowledged. The work women do in households is often considered lower in status compared to working outside. And again, this is an issue of dignity. And if I talk about female health workers, they are perhaps the lowest paid and most vulnerable in terms of their financial status. So I'm going to move to the third part of my presentation, which is that, based on some of the work that I've been doing, and obviously there is a universe of issues out there and so many people who are working in this field, and that's so good to see. But I'm going to focus on three particular areas where there has been some progress, but that issues persist, and that the reality of women's life is very fast changing. And of gender equality, gender relations, all of that is changing. The first one is child and early marriage, marital pressure, and consent. I mean, I think we see a lot of some of this play out in the media and so on, but I'm going to focus more on the empirical aspect of it and what is really going on, what are the issues that we are seeing from the work that has been done in the field. The second one is fertility pressure, or pressures that women face to have a baby or have a baby early or have a male child. Or I think these days a lot of women are increasingly grappling with infertility. So it's a whole gamut of issues that relates to fertility pressure. And the third is women's experience of care, and what does the health system offer to women and how are women sort of navigating that. So the first issue is, marriage, particularly. I think this is one of the most interesting, perhaps, issues to be working on, and also sometimes the most heartbreaking. We know that today marriage, in a way, is a very universal social institution, but it's fighting for its relevance. But we're not talking about marriage in sort of the more, I would say, urban liberal spheres. We're talking about girls being forced to marriage prior to age 18, which is a crime in many countries, but still continues to happen. And we know today that, marriages are also around the world structurally changing, meaning that you see changes in family structure, you see rise in nuclear households, the joint and the extended family system is fast disappearing. We are seeing people exert their sexual rights. In many countries, it is possible to have legal rights as well. We're talking about education of women and how that's changing marriage. So all of that is playing out. But despite all these sort of, I would say, big social currents, we find that, the recent data that was released by the NFHS 6 showed that in India, 20% are still getting married prior to 18 years of age. this is around 1 in 5. I think in the last NFHS, it was around 24%. So we have been through the NFHS rounds, been seeing a steady decline. A lot of the, and I would say, India has made like a big jump, because I think it was around 10 or 15 years ago where we were at 48%. So, we have halved it. So we have to congratulate ourselves in a way at being able to achieve this. But work still needs to be done. Until this number goes down further and further, I don't think we would have achieved what we want to achieve. We also see in the recent round that 6% of 15 to 19-year-olds are already pregnant or mothers. And we know that getting pregnant so early can have major physical and mental health consequences on young girls. But child marriage is also, has a lot of, how do you say, deep impacts on the life course journey of a woman. So we know that child marriage is associated with loss of schooling. So marriage means that you no longer go to school, or education doesn't remain a viable possibility. And that sets the trajectory for future, because it really means that you have almost no way of reclaiming any economic rights in the future. We also know that child and marriage is associated with loss of agency. A lot of girls who get married very early have no voice in their marital homes. There is evidence that shows that they often get isolated. They lose their friends. They lose their family networks. There is very early pressure for pregnancy, lack of decision making control, lack of knowledge or access to family planning, and much higher likelihood of violence in marriage. So this graphic actually just shows, this is actually data from NFHS 6 that shows where we are in terms of the hotspots. We're doing very well, but much more needs to be done. We also see this issue of marital autonomy, consent, and choice that is playing out in many countries. It's not just true of India. Is that girls who marry particularly young have either no choice or control over the choice of their partners or the circumstances of their marriage. So it's everything is in a way decided for them by their families, and they become extremely vulnerable in the ways in which that they engage, and these have enormous health consequences on their pregnancy outcomes. They often are, as we said, are forced to make early to demonstrate early pregnancy. But today we also see changing dynamics of marriage. So I don't want to just leave you with the bad news, but is also that there are currents that are changing. You are also seeing, particularly in urban spaces, that fewer and fewer people are choosing to get married. A lot of young people are choosing to cohabit instead of marry each other. And I think, I'm not making a moral judgment, and I don't want to get into that space. But the truth is that, you know, how that will play out in terms of their health, in terms of their risks, I think we don't have enough evidence on. Similarly, we see a change in also having more and more egalitarian marriages. Egalitarian marriages are marriages where women and men are either both working, and then there are marriages where women are working and men are not. So we are also seeing that trend in isolated urban spots. And we are seeing this dynamic play out in the households where there is increasing discussion of childcare, leisure, paid work, housework. How do these issues, how are they navigated by women? The second theme that I want to talk about today is fertility pressure. And I have actually in my work often worked on this concept called reproductive agency. And many people call it reproductive rights. I think a lot of people in the US are calling it reproductive justice, and particularly so because a lot of the discourse around abortion is not just limited to women's rights, but it's now a kind of a aspect of discussion in their legal system. And people often call it reproductive autonomy, something, that often gets used interchangeably. But like, Sneha had started with this, my body, my choice, bodily integrity is fundamental. If you can't control your body, what can you control? So that is sort of the underlying idea of reproductive agency. But the reality of women's lives in almost all countries is that there are a number of actors who really exercise choice on what women must do. So it can be parents, it can be husbands, partners, boyfriends, in laws, community elders, even, and the state. So, that becomes a real question of how we see. And the thing is that the questions of reproductive autonomy, or agency, or autonomy are not the same in all countries. In every country, a different sort of battle is on. And I don't, I find some of these, these comparisons that we often see cross nationally, like they're a little problematic because different countries are at different stages of their evolution of these rights. So India's laws actually have been very progressive, I have to say, but the implementation has been somewhat not so great, although we are moving forward, but we always wish we could be better. So when we say reproductive agency or autonomy, what we say, and this is the definition that I use in my work, it means women can control whether and when to get pregnant, whether and when to practice contraception, and which method to use, and whether and when to continue a pregnancy. So this becomes very important. Um, as we have often said, it is impossible to disconnect reproductive agency from other aspects of your life, from economic agency, meaning the economic freedom you have, your decision making, your freedom from violence, and participation socially. But one of the things that is very different between, particularly, I would say, South Asia or Asian countries, is that we don't have sometimes an absolute idea of agency in the ways in which we have actually operated. And I'm not saying it's a good thing or a bad thing, but we often have relational aspects. So, we are constantly negotiating and being shaped by that agency around with our social systems. So as I said, I'm going to be very brief, but India has achieved the total fertility rate, which is an ideal one, and so we should be, of course, celebrating that. But there are several issues that still continue to persist despite our achieving our target, and these are related to the pressure that women often face, to achieve fertility early in marriage. So if a woman, has not had a baby 5 years into marriage, people start talking. So, there's always this pressure that women and sometimes even men face related to that. Similarly, pronatalism. Pronatalism means that everybody must have a child. So women and men in marriages are often conditioned to believe that why won't you have a child? And we now see a lot of men and women in marriages making the choice that they don't want children. But there's still that pressure from or around pronatalism in their social sphere. Similarly, we are increasingly seeing infertility, which has biological, perhaps some lifestyle and other factors related that is leading to greater infertility. But the pressure that women are facing as they are navigating that is very painful. And at the same time, increasingly couples don't have support because we are navigating from joint and extended family systems to nuclear systems, and couples often are really, I think, modern urban couples are really navigating the pressures of economic demand, being in workspaces that are very stressful, very tough, and also navigating childcare. So this becomes a really important issue. Then we continue to see male child preference operate in our society. Now it's a lot less than it used to be, but recent, I think, sex ratio indicators have again seen a bit of a resurgence of this trend. And so all of these factors actually affect women in terms of their physical health, mental health, And we are seeing, particularly for the 15 to 29-year-old female group, married or unmarried, we are seeing much higher pressures and much higher suicidal ideation rates. And that is something that we really need to collectively address. The last point that I want to talk about is women's experience of care. Now, again, I think the central question that we all face today is that are our health systems really responsive and respectful to women? And how does this experience, and sometimes the experience of care is very traumatic, how does this experience affect their health outcomes, their returning back to the health system? So we often talk about this concept called continuum of care. Are women coming back to a health provider once they've been disrespected? And how is it affecting their experiences of care? Now, this issue of obstetric violence has recently, in the last decade or so, become very important. Now, obstetric violence means violence faced by women, usually in delivery, but also a little bit in antenatal care from the health system. And you might wonder that why would anybody be violent or abusive towards a woman who is pregnant, who is about to deliver, who is going through perhaps a very challenging biological and psychological experience? But it does happen in our health system, and I think part of it relates to either the physical or the verbal abuse that women face in towards their delivery, or closer to their delivery, in terms of any treatments that are done without their consent. So we have evidence of unnecessary episiotomies in the work that is done in Assam, etc. We also have neglectful care. We have, there is some evidence that women are often made to go through procedures without their explicit consent. They don't know the meaning of what they are going through. So a lot of it relates to how we need to think about women's experience of care beyond maternal mortality, because we've been so obsessed with saving women's lives. That's fine, and that's really important, but we also need to know and be conscious of what kind of care are we providing them. So respectful care becomes a really important question in our care. Similarly, in family planning, we have talked about contraception, abortion, sterilization. All of these issues have been hotbeds of politics for us, particularly those of us who work in sexual and reproductive health rights. So we often see that a lot of contraception is geared towards women's bodies. But who decides what a woman should be done? It's usually her husband, maybe her mother-in-law, maybe some relative, right? But what is happening to a woman, and all of our contraception is really geared towards women. We often also find that, the role of counselors is very, very challenging. Women are often counseled, but they are not always the decision makers. I think there is a lot of evidence from sterilization world where we know that misdemeanors have happened. There have been botched sterilization efforts. Women have had to get hysterectomies. So many of these issues continue to boil our blood. We often also see that the abortion stigma continues in our society. Women are unable to talk about their need and desire to have a baby or not. And of course, there are a lot of these myths and misconceptions that continue to operate in our society. Abortion also in the public system especially is around managing red tape. And given how time sensitive it is as a procedure, the needs of a woman often are relegated, and what is really important is getting through the bureaucracy of it, right? So all of these issues, each of these issues, even if some of you are interested in looking in, each of these provides so much for us to do even now. So I'll end with saying, what are the key takeaways and directions, or some of the key takeaways and directions that perhaps you can take away from some of this work. One is, of course, that equity and norms are some of the most important social issues, developmental issues, healthcare issues that we face today. We need to look at it beyond the question of investment or economics or what is good for the GDP, but think of it as a rights issue, as a justice issue. We know that the reality of women's lives and their health are deeply interconnected. Studying gender equity as, the social determinants is very, very critical today. So, I think even whether you are a medical practitioner or not, these are issues that are very important in the healthcare system. We know that there are many achievements that particularly India has achieved, be it child marriage, be it fertility rates, so on, but much more needs to be done, and from a life course perspective. And lastly, child and early marriage are still putting women, 20% is a big number in India, on an irreversible trajectory, harming their growth, their development, and their future. The pressure for fertility and infertility pressures are constantly co-varying with each other. These are important issues that affect the physical and the mental health of women. So, going through repeated fertility procedures are affecting women's health, physical health, mental health. Enhancing women's reproductive agency is an important instrument, but agency cannot be disconnected from other aspects of women's lives. And as healthcare practitioners, we need to ask if our health systems are truly responsive to women's needs. Do they treat them with dignity and respect? And these gaps in health services can provide important insights into the complex dynamics that are driving women's interactions with the health system. So with that, I want to thank you for inviting me, and I look forward to your questions. Thank you.
Thank you, ma'am, for an insightful session. Any questions? Please go ahead and ask questions. Any questions?
Or reflections. I don't mind people reflecting also. Anything that they don't agree with. Yes, please.
Okay, Anmol, please go ahead.
Good evening, ma'am. First of all, it was a very great and enlightening session since the past 30 odd minutes. I really got to know several new dimensions of gender and public health, how they both are intersecting with each other. Ma'am, you talked about obstetric violence and pregnancy related issues. So, currently, we also have a topic of research related to postpartum depression. So, could you throw some light, ma'am, on how well is this issue being currently studied in India? And are there some initiatives, if at all, to tackle the postpartum depression issue in India? And if there are, then how successful they are?
Thank you for this very important question. In fact, I have a paper from several years ago in the EPW, which is a review of postpartum depression. If you like, you can look it up. But, one of the most determining factors around, so firstly, postpartum depression is a really important issue, and it is often, not recognized until much later. But postpartum depression also has a certain definition. So if you look up the definition, so women after delivery, actually for at least a couple of months or more, go through tremendous hormonal change. Some of it affects their physical health, some of it affects their mental health. That is not postpartum depression. The postpartum depression happens if that persists almost up to 6 months. So the question is that most of our healthcare system, and I would say perhaps public but also private, it is very much geared towards a successful delivery. But the post delivery care, and particularly services related to post delivery care, are very weak. There are often women are given no counseling as to what they would expect. And this is a really big challenge. And one of the determining factors of postpartum depression is the amount of support that you receive. So, traditionally women were often women spent their first 40 days in their natal homes, meaning the homes of their mothers. And, the idea was that somehow, I think that women felt that they were cared for better. Their parents like cooked for them and took care of the baby and, gave them the right support. Increasingly, some of these traditional patterns are going away. And women often, after having a baby, are not receiving the kind of support. In fact, they are coming back, they are living in stressful environments, they are having to do a lot of domestic labor, they are not having the recovery systems that they need. So I think, to be honest, we really need to invest in postpartum care. In fact, if you see the experience of many Asian countries, if you look at the experience perhaps in Korea and many other countries, you will find that there are many, many services for postpartum care. In fact, those societies have kind of commercialized postpartum care, which is its own problem. We may perhaps can't afford that. But there are many healthy practices related to the care for women postpartum that need to be brought out. Now, obstetric violence, as we study it, is violence that women have faced in the health system. It's not violence at home. But if you see the work on postpartum depression, particularly for women, I think we find that women who have delivered a baby girl actually go through a more stressful environment than, I mean, I'm not saying this happens everywhere, but research shows that if you have a female baby, that you are more likely to face or to less likely to face to receive support and to often have a stressful environment at home that can aggravate postpartum depression. So it's a kind of a mix of biological factors, of social support, of societal factors, and also the recovery that women should be having after a delivery, but sometimes don't get the opportunity to. So I think it's a very important question. I'm really glad that you are studying it. But remember that postpartum depression is not the immediate, but it's something that is sustained. At least the global definition is something that is sustained. And if you look up, there is an Edinburgh scale or something for postpartum depression that best captures how postpartum depression should be measured. So have a look at it. I think it's called EPDS or something like that. So thank you for that question.
Thank you, ma'am. Thanks a lot.
Thank you, Anmol. Next question. Any other questions we have? Swale?
Hello, hello,
Yes, you are audible.
hello, ma'am. Thank you for this enlightenment session. And I want to ask the question why does female suicide continue in India despite the PC PNDT Act banning prenatal sex determination? Yeah, so India has prohibited prenatal sex selection since 1994, yet gender biased sex selection persists in several regions. So, what is the reason and how can we control this?
This is such an important question. In fact, if you look at the recent data, you are seeing that there's a resurgence of it. And I was seeing, actually, because my university is based in Haryana. So I was looking at some data for Haryana, and we are finding that some of the districts in Haryana are seeing a resurgence of, the sex ratio being very skewed. And the government has immediately gone into action to ensure that there is a following of the PNDT. So PNDT is an important law in India that is very, very, it's a very strict law, and you will see a lot of really good providers follow it. But can I just say that law is law? But what really matters is social and gender norms, the norms that are taking place in society. So you cannot actually expect law to solve all the problems. It helps. For example, you have a dowry law, but we see dowry. You have a sex selection law, but so until you change the gender norms or the underlying, the status that women have in society, how we view them, how we value them, you're not going to see the change. So I think it's really important that we work on. And the problem is that gender norms are very hard to change. It's very hard to change the ingrained attitudes and sort of what people have believed so strongly for so many years. How can you come in and change it with one law? You can't. So I think the laws are a start, but unless you have interventions that change the ways in which people perceive young girls, that is not possible. Now, many states have had what you call conditional cash transfers also. So these are, these are, if a girl is born, Haryana has been one state, Bihar has been one state. So these have also again encouraged a little bit of the status given to women. But again, economics is not enough. You need to change the underlying norms and values and attitudes that people have towards gender relation. So that is very important. I don't know if I answered your question,
Okay.
but
Yes.
yeah.
Thank you.
Rightly said, ma'am. Any other question? Anyone else wants to ask a question? Please go ahead. Okay, I don't think any more questions. So, to end it, thank you, ma'am. Thank you so much for your insightful session. Thank you so much for giving us so much time. To summarize, ma'am talked about the key concept, like the difference between the sex and gender, the power, the gender norms that exist, the life course lens, the difference between the gender neutrality, awareness, responsiveness, and gender transformation. Talking about she also talked why does gender equality matter to us, why we require what we require is equality in terms of the opportunity. Some issues, some very important issues that she pointed out was the gender gap. She also talked about the dignity of the women, the policy implementation. There are some places that we lack. The issue of the reproductive justice, the child marriages, fertility pressure, and a lot. So finally, there's a need that the women need to be decision makers and need to imbibe in themselves what we call my body, my choice. So thank you, ma'am. Thank you for such an informative and insightful session. Thank you for your time.
Thank you so much. Thank
Thank
you
you.
so much.
Thank you.
Okay. All the best to all of you. Thank you.